So when I think about this, I tend to think, okay, we start at the most broad level of information collecting to understand the background of this individual and continually refine our assessment process until we arrive at a point of being able to say, these are the underlying challenges for feeding for this specific person. So now we will develop a specific intervention to address it. In arriving at that intervention, we look at coordinating services, identifying the immediate priorities, evaluating progress, and essentially family training. One of our speakers today mentioned that we learn as much from our families as they learn from us, and that's absolutely an appropriate statement. We find that the best way to understand the feeding treatment is for the families to give us feedback about what will and will not work in their home, and from that point, we can design anything to match it. If we say this has to happen this way, change your home for it, we can guarantee you that in the 7 days before they see us again, they will maybe try but likely not be successful. If we say, tell us about your home, teach us what happens, now can you try this? We are on the right side of the conversation and able to execute change. So it's absolutely an essential component that our families are actively involved in the treatment process and that they understand that we will move this process with them and with their guidance, but that we will be the benchmarks for helping them understand the most critical priorities, but that they will be couched comfortably within their family. We want to think about those essential priorities in a couple large areas. What does our muscle tone look like? What are the structures of the mouth that need to be addressed and made more mature and competent for the learner? We'll often think about the exercises that can be done, some of them often quite fun for the families. So we may set up just practice opportunities with straws and whistles and other things that are easy to incorporate at home, but work on that lip closure, because maybe we have a learner who can't form the lip appropriately to execute that. So we have a wonderful supply of these amazing whistles that are just so fun for our learners, but at the same time give us the practice we need. We move from those more fun activities to more serious ones designed to improve the competencies, but we move in very slowly. We want to be thinking about how do we practice the skills, ignoring the new foods so far, just practice the competencies, improve the skill set, and then introduce the new foods. When we're doing so, we think about behavioral interventions that are most essential here. Some of the most commonly well-applied behavioral principles are extremely effective when treating feeding if you understand the underlying problem of the challenge. Shaping behavior continually, grading ourselves closer and closer to the appropriate target is essential. We start as close as we can to the next step of development and then move forward, rather than taking large leaps that to the family will seem quite difficult and truly for the learner will be very, very difficult. We think about procedures to avoid escape-maintain behaviors. How do we extinguish those responses while always replacing them with better and more functional skill sets? That's where we come into this alternate response training. We speak a great deal with our families about the other skills that their learners need. It's wonderful if you come to the clinic and I can get you to eat 30 new foods, but if you can't go to the family's table and sit, those foods are fairly non-relevant to your social development. Rather, we might need to think about coming to a table, sitting, knowing the foods. These are some examples of common hierarchies that we use. In almost every level of treatment, we think about gradually fading our process. So perhaps moving from just smelling a food to independently feeding it, or perhaps going from a pureed texture, a very easy to take in texture, to its natural form. We also have many learners who require desensitization to visual, olfactory, tactile, and temperature components. It's not uncommon for us to be working with a learner where the first set of goals is to enter the room and just see non-preferred foods and maintain a calm position. If that's your next step of progress, then that's where we'll be with you. And then after that, we might move to smelling it, to touching it, all of that well before eating it. But at each step, we've provided you with intense reward for very small gains, setting up an important momentum. We're asking for major change on a behavior that's often intracted for years and years and years before we're able to provide intervention. It's absolutely essential that every intervention is individualized. We can't say that enough. And I think it's of great benefit to all of us listening today that so many of our conversations this morning have discussed individualization, whether it's the diagnostic profile or whether it's a specific component of that with respect to your feeding. We will individualize every treatment rather than forcing a prescribed treatment that has no flexibility into a family system. When we're doing that, embedding choice and that oral motor training, these end up being among the most essential components. They're the most commonly shared features among all of our interventions. When you're dealing with feeding, it's absolutely implied that you have to be thinking about the free will of the individual. There's all these new foods that they've never tried, and it's not for us to say which they will like or prefer, no more than it would be for me to tell any one of you to like a food you don't. But it is for us to give them the ability to eat a nutritious profile, to make good choices, and to say no when they don't want something, and look for alternate substitutes. If I don't like one food, what are other things that are also healthy for me that I can select? So we have to be thinking about that. We try across our sessions to keep track of some core pieces of information. Some of you who were with us yesterday may remember we talked a bit about looking at factors such as cumulative foods mastered. We want to be helping our families understand the trajectory of the gain, and we want to also be making sure that we're not seeing a leveling out or plateau of progress. That while in treatment, we're seeing a continuous acquisition of foods going from some stage of early resistance all the way through full mastery, meaning you will eat it in the community independently in an appropriate context. Such a simple graph like this is amazingly powerful with a family. It's very clean, it's very simple, but we've had families who want to take this and show it to family members to help them understand the progress, because it's just a nice acquisition. But for us, it also helps us monitor how are we doing. There's many, many other levels that we won't speak on today, but this is one of the most common. Others are looking at the number of sessions that we take to master foods. So how long do foods take before they move forward to a point of mastery and acquisition? By analyzing this information, you learn a lot about your patient. You can understand profiles of foods that will progress quickly and those that will go more slowly, and start to develop hypotheses about some of the competencies that may be necessary for those that are moving more slowly. And finally, we think about, when do we end treatment? It's a very complicated question with respect to feeding. One of the most essential benchmarks for us is that the individual, him or herself, or the caregivers working with the patient, can introduce a new food and bring it fully to mastery without any of our participation. At that point, we feel much more comfortable with the patients discharging and moving to a more periodic treatment with us. You can imagine that in any family, addressing an issue as complex as feeding is quite powerful. At a family level, particularly at a disruption to that family system level. So often the families have accommodated significantly for the feeding difficulty, and here we're faced with a major level of change. Because of that, terminating treatment is a very sensitive issue, and we're very careful with our families about moving forward slowly to progress away from treatment and into a greater level of functional independence. When they've done that, we are always obviously available to them for periodic consults, but we find that the families are able to take and move forward, and we have good maintenance of feeding profiles for our learners. Yesterday, we were sharing some stories with some of you about some of our learners moving forward and sending us pictures of them now on vacation eating meals, and it's absolutely one of the most wonderful things we can imagine, but we can also appreciate the work that went into that vacation, something that I know for so long I took for granted. I couldn't imagine how much work went into getting one child to go on vacation, and so we appreciate so much that they do that. But it also shows us that they are continuing to master new foods and expand social opportunities. Because, of course, feeding is such a socially mediated behavior. If you don't address the social concerns, you will struggle so much with just addressing the food. So in closing, we'll encourage you to think about feeding from a perspective of taking in a diverse profile, but not that alone. The entire social relationship that wraps around the feeding is absolutely essential if interventions are to move forward. So please consider that with so many of the learners we work with, the first steps to addressing feeding may be addressing other underlying social competencies. The ability to share time with others, follow a routine and schedule, and participate in larger community settings. These can all be appropriate targets and maybe should be considered before the first bite of food is even taken. If we take that stance, a more holistic version of addressing feeding, we find that the social value of it improves dramatically and that the intervention is able to sustain and maintain momentum across the lifespan. So we thank you for your time again and look forward to speaking with you.
Thank you very much.